when do we use it? This thing is, the values-based discernment is actually required for major decisions like this. So any decision that affects significant interests. If we're transferring a hospital, like Pittsburgh Mercy, we sold the oldest Catholic hospital east of the Alleghenies. We sold it to University of Pittsburgh, right? Well, significant interest. I mean, all the people who had funded it through the years as a Catholic institution, they wanted some accountability, right? So decisions that affect significant interest or significant populations. When we decided we were going to do think about offering a just wage, whatever that was, a just wage affects not only the people who are being paid just above the minimum wage, but the wage compression. Think of all the other employees, for example, environmental services, who are already making $10.50, right? And we raised the ones that are lower than that up to $10.50. Well, you got to imagine that those people who are making $10.50, hey, what about us, right? So anything that's significant interest, the opening and closing of services, significant HR issues. Many of our sites are in competition with hospitals that are offering what is called legally domiciled adult benefits. They're other than Catholic institutions. Well, if we were an employer that we're not offering it, we would have, people aren't going to stay with us, right? So significant HR issues, whether it's just wage or expanding benefits to others. We use it for bioethics. And as a general matter, this habit, as we go through this process, when someone comes into my office and they have a problem, I basically go through all these elements. So we do 3 phases of this. And usually when people are doing values-based decision making, they just use this. Like if in your clinical bioethics course right now, I bet you that people are saying, well, what's the issue? What facts do we need? Who's affected by it? What are our options? That's where most people, enter this discussion. But when you're in a complex organization, we're in 11 states, we have 35 hospitals, all these things, we want to make sure that the right people get to the table. So we have a preparation phase. And what we do is we ask some questions. We ask some questions about, how big an issue is this? Do we need to use someone other than the clinical bioethics committee and the like? So we do some preparation. Then we do the decision-making and the follow-through. Now, I want to start with a case that just happened. It happened here in Philadelphia 4 years ago before an important law passed. But we had a lady she was 48 years old, so when she was about 46 and a half, she came in and she had a mitral valve replacement. She was uninsured at that point. And so after she left our hospital, she had no care. Because she had no insurance, and her husband was unemployed, so they had no access to stuff. So she comes to our hospital on a Friday. Well, what happens was she gets very sick. She has an infection because of the mitral valve replacement and the like, and she shows up at she doesn't show up. She has a fever of 105. She says to her husband, "I'm going to go take a cold shower and see if it brings this down," because she couldn't get health care, right? So she goes up to the bathroom. She's up there for about 15 minutes, and her husband starts to worry. What happened to her, right? So he goes upstairs, and she had collapsed in the tub with her face down, and she had become anoxic, right? So no breathing, right? Now, the general rule of thumb here is that for every minute you're anoxic, you're not getting any oxygen, you lose 10% of your functioning. So she was probably up there, and of course her husband sees her, and he rushes to the phone to get the EMS, and they don't come for another 8 minutes or so. So now this woman has been anoxic at least 15 minutes, right? And so for the 10-minute rule, she's in significantly bad shape, right? They bring her over to our institution. She had said, anything happens, and I can't regain 50% of my functioning, then stop everything. Well, so here's this woman. Now she's when she was anoxic, she's in a coma-like state, right? And she's probably been like that for 15 minutes or so, which means that she's probably not ever going to come out of it. Usually, it would take 3 months to analyze this, but studies of persons who are in vegetative state, it usually takes about 3 months if you know what was the cause of why they are in that vegetative state, right? So the husband says, and by the way, this is happening in the Philadelphia diocese. So medical ethics isn't just an abstract thing. It's happening in dioceses where there are bishops and others who have very strong opinions about this. So her husband says, you know, Friday, you know, well, actually, he waits till Monday, and he says at that point, you know, enough is enough. Look, we're going to stop everything, including, but she didn't have a peg tube at that point. She just had a central line where she was getting alimentation and the like. So it was, but still, it wasn't enough to really keep her, you know, body weight up and things like that. So he basically said, I don't want anything, and I don't want you to feed her. Well, of course. And he made the unfortunate comment. He said he told his daughter. This woman has 3 kids. He told a daughter that mother's dead. She wasn't clinically brain dead, but soon enough she probably would have expired, right? Well, as the staff, the nurses in particular, said, "Wait a minute, we're in Philadelphia. We're in the Archdiocese of Philadelphia. You always have to feed people." So they said, if you withdraw nutrition and hydration from her, or for that matter, other things, you're killing her, right? I mean, talk about a rush to judgment. You know, you have a guy whose wife is now in this vegetative state. He has 3 kids, and he's facing a really horrific decision. You know, should the person you love, shall I remove nutrition hydration, right? So we're going to take this case and we're going to use the values-based decision making to sort of pull it apart. So the first question I have for you is, how big a case is this? Is it, like, for example, would it be good enough to just call the ethics committee, or is it a bigger case? See, because the bigger the heft there is of a case, perhaps you might need a different kind of mechanism to think about it. So we go through questions like, well, who are the number of people will be affected by this? Who's going to be affected by this? Who's going to be affected by this? You're not going to be couch potatoes. I'm going to drag it out of you. Who's affected? Yeah, go ahead.
The family who's waiting on her recovery.
Yeah, so the family, obviously, is affected by it. Who else? Yeah.
I guess like future people who want to do the same thing.
That's right. So anytime you make a decision like this, that's a precedent setting, right? Yeah, who else?
Does it affect the religious community involved?
Yeah, absolutely. You know, so this is happening at a Catholic hospital. You know, are they not following the church's teaching? Who else? Yeah.
The nursing staff, maybe?
Yeah, the nursing staff. I mean, they're hopping mad. You're killing the person, right? So they're alleging, right? And how would you know whether or not it was in fact a killing, right? Anyone else? Yeah.
The patient herself.
Yeah, the patient. You know, she's going to be taking a dirt nap soon, right? If they forego it, right? That's I taught in Missouri, and that was the nursing staff used to always talk about. Oh, they're going to go take a dirt nap. So the duration of the impact, it's going to affect all those people. The weight of the impact, well, you know, is this an act of termination of treatment, or is it something more dastardly that would qualify, for example, as killing someone, right? The closeness to core values, past commitments. Well, the past commitments, it's a Catholic hospital. We don't bring people in and treat them to euthanasia, right? Killing them. We don't do that, right? So there's a lot of things going on here, and relationship to strategic direction. If it were, in fact, and we haven't really established it was a killing, well, imagine if not only the Catholic community, but the local community said, hey, you know, over at Holy Smoke Hospital, they kill people. You don't want to go there, right? So before we ever sit down, because it's very easy, you know, on the floor, people, there's a rush to judgment. Oh, we've got to make some decisions. Oh, that's killing and the like. We tell people one of the most important value is slow it down. Who do you need to have at the table? How big an issue is this? And we also ask questions based on the nature of the issues. Who should be part of it? Who should be part of the conversation? How frequently does this happen, right? It happens a lot. People show up at our hospitals and they die there. They are in our nursing homes. If you get into our nursing homes, most of the people in nursing homes die. We don't have a lot of just chronic illness there. They go there and they die. What departments? Well, the nursing department, the medical department, the people that are treating her up in the ICU are affected. What other entities will be affected? Well, it's not only Holy Smoke Hospital, but it's the diocese and the like. and who would have insights. So we ask these questions before we ever sit down. So let me ask you, who do you think should be at the table, and why? Yeah.
Well, you should definitely have the family, the staff who
Uh-huh.
are directly
Okay.
associated with her.
Right.
You'd probably want an ethics committee,
Right.
a legal committee.
Uh-huh.
You probably want some top people in the hospital, but if it is a religious hospital, you want I'm sure a religious person would want to be present.
Uh-huh. Yeah, and what's in Catholic healthcare, that person tends to be what is called a mission executive. Sometimes it's a religious woman or a priest, but there's actually a lot of lay people these days. Half of across our system, more than half are lay people, and it's a good paying job. So I don't know if any of you are religion majors or philosophy major. I was a philosophy and then a theology major. And what happens to those people? You know, well, actually, you can get a really good job within Catholic healthcare. Big opportunity. So the mission person would be there, right? Okay. Well, let me ask you this. Do you think that it'd be okay? I will come back to this, but do you think it would be okay just for the ethics committee to deal with this? You added some other people, like the family, and you thought maybe some administration and the like. Not many administrators are on ethics committees, but do you think that would be adequate to the task?
Oh, me?
Yeah,
Oh,
yeah.
Yeah, yes and no.
Hedge in your bets.
Okay, yeah, I think yes if they're...
You'll do well in philosophy, right?
That's right. I think yes if they're not just thinking in a religious perspective, because the religious factor might not be important to the patients themselves. Like, they might not be extremely religious, but no if they are thinking only in terms of like the Catholic rules.
Uh-huh.
So if they can
Yeah,
like,
this woman, right.
it'd be one thing, but if they are going to be biased, then absolutely not.
Okay, that's good observation. I mean, one of the things... Oh, okay. Well, you know, one of the things, and this is just sort of a sidebar conversation, at all our sites we have what are called consultation teams, not the whole ethics committee, but teams of people who are educated to know both basic bioethics as well as what's the Catholic spin on it. But when they show up, what their purpose in being there is to facilitate a good decision, not to make the decision. But a lot of people oftentimes are confused, like, oh, this is a Catholic hospital and we're going to tell you what to do. No, that's not exact. They're there to help. And this woman, by the way, was not a Catholic. She was at a Catholic hospital. And you'll see as we go forward, that also creates a tension. It's not only what she and her husband wanted to do, but there was also a question about what would the institution allow? Could it go along with it, right? So we'll put that one in the moral parking lot about who should be there. Let's just take for the moment that, okay, an ethics consultation team is going to show up and do this. Now, the first phase was, well, who do we think needs to be there? And the answer to that is, okay, we think that the ethics committee could deal with it. When we're done, we'll revisit that question because maybe something other than an ethics committee was really required for this case. Then we move into the decision-making phase itself. And in the decision-making phase, the first question is, what are we talking about? What's the question? Because actually, what happens in ethics, oftentimes, it's really, there are many moral issues. And you know what, a real big problem is that if there's a rush to judgment, this is the question. Well, you will go gather all kinds of facts, and you'll make a decision, and it may be inadequate to the task. So let me ask you, how would you frame? What do you take the questions here to be? Don't rush me all at once. What do you take the questions? What do you take the moral issues to be? Yeah.
Sorry, this is actually a question for you. Was the couple Catholic or?
No, the couple was not Catholic, but they are in a Catholic hospital, and so that no, they're not Catholic, right? But what do you take the issue? Well, one of the issues is a conflict between religious perspectives. There's an issue, right? So a religious conflict, huh? Religious conflict. What else would you? Yeah.
Well, I did a paper on something like this.
Uh-huh.
I focused on personhood and what defines personhood.
Uh-huh.
Because if you look at it from a Kantian perspective or
Right.
neo-Kantian sort of
Mhm.
human rights perspective, it's defined by autonomy.
Uh-huh.
And obviously, this woman's not autonomous.
Right.
So therefore, she may have no inherent dignity from that perspective. But there are other perspectives whereby dignity is conferred, like via almost like a third party, sort of by God. And if God infuses personhood with dignity, then there are no sort of attributes or characteristics
You can't lose
that
it.
you justify
Yeah,
by
right.
it.
Right. So you're pointing out importantly that you could imagine bringing people to the table, and some believe, and there are schools of thought that would say, if you're sentient, you can think and the like, and if you got someone who's a vegetative state, she's not expressing her autonomy and she's not probably thinking about anything, right? So people would say, well, no, they're not really persons, so we don't really have, if we were to get rid of them, what's the big deal? Because we're not killing a person, right, on one account of it, but from another perspective, you could say, theologically, it's conferred by God, and you can't give that one up. It's an inalienable right. It just comes with your genetic package. What else are ethical issues that you see here? Yeah.
Is withholding treatments or like sustaining procedures immoral?
Yeah. Is that withholding? Is it withholding immoral? Okay, or not permissible, or okay, unacceptable? What else would you say? There's a bunch of things packed in here. Yeah.
Her advanced directive.
Yeah. What's her advanced directives? Okay. She was clear. What would you say about that? It's clear he was her duly appointed person, and he knew her wishes on the matter.
Did you have it in writing?
No, yeah, he did. He did have it in writing. But what's interesting, and this is where 6 months makes a difference. This was before a state law in Pennsylvania went in that said, if you appoint someone and you want to withhold nutrition hydration, the person has to do it. But this happened 6 months before that law took effect. So actually the law kind of creates, well, we could have done it then, but we can't do it now because she didn't stipulate the nutrition hydration part of it. And any other things that you see here? Well, the questions at the end of life. There's really two big questions that kind of go together. And they go hand in glove, and it's hard to disaggregate them, to pull them apart. But one is the question of who gets to make decisions. And the general storyline there is people who are capacitated, who are given informed consent, they can make the decisions, right? So usually patients who come in and tell us what they want, we go quite along with them. When they're not able to do it, we look to what they've said previously. Either they've done a treatment directive. They, for example, say, I have a living will. If these conditions happen, do this. Or they say, well, I want you to listen to my husband. And by the way, when it comes to advanced directives, only about 25% of the population have it. So the most of us are the great unwashed. 75% of the people who show up to our medical sites don't have one of these things. And so there's the question about, well, how do you figure it out? How do you figure those questions out in the absence of a clear directive or them telling you? So at least one of the questions is who decides? Then the second one, and this is really specifically to end of life, is what's the basis that you're foregoing the treatment? What are the reasons? There's a lot. People give a lot of reasons for going. It's bad quality of life. There's a theory, quality of life. People say, oh, it's futile. Feeding that person, she's never going to come back. She's never going to get back to where she was. So they give the justification. What's the basis for it? Oh, it's futile. People use a lot of other ones as well. The person decided that they wanted to forgo it, an autonomy or a self-determination. So because they chose it, simply because they chose it, that's good enough. And then there's one that comes out of the Catholic tradition, which we have to pay attention to, which is, are there lots of burdens that are created and not a lot of benefits? So the basis for the termination, autonomy and self-determination, just because someone asks for it, or it's futile, or quality of life, or the burden-benefit ratio. There is a third question. Oh, well, let me go back before I get to that. What's interesting about this, and you see it all the time on the floor among nurses and others, if they don't like this answer, they don't like the reasons are right, immediately they say, oh no, that's not the right person. So the guy says, well, my wife said that if she couldn't get 50% of her functioning back, Oh, well, and that was the basis why he was asking for it to be done. You know, it's sort of an autonomy, self-determination along the lines of she gave an advance directive, right? No, they didn't like the answer. And what happens is that it has a reciprocal effect on this. If you don't like this, it's sort of, we go through it all the time. You have someone who's elderly, right? And just because they're old, everyone assumes, oh, they don't have their marbles, right? So, and the older person says, I don't want this, or I want my treatment this way. And what do people do? They say, oh, well, no, they can't make that decision, you know? So these things go hand in glove. But specifically, and this question about end-of-life care is more about this question in my mind, is do you have a good enough basis, as opposed to this. I mean, it's not irrelevant. You always, the first question when a nurse or doctor calls me, what do I say to them? Let's figure out who's the right decision maker. But even if you got that clear, there's a second step, like what's the basis upon which you're going to make that decision. And there's a third one, which in Catholic hospitals people get totally confused about, and that is, can the organization cooperate with it? So let's say that everyone on the floor was totally copacetic with, okay, we'll forgo the treatment, right? Well, and so they're ready to forgo the treatment. An administrator, the mission executive, has to say, wait a minute, is that something that can happen in Holy Smoke Hospital, right? So there's actually a third question. I'm not going to deal with that one today as we go through this values-based decision-making. I'm basically going to look at that one. Now, then the question is, so the first thing is, what are we talking about? And oh, by the way, so here's what we're talking about. These are the questions generally. In that first step, one of the questions we always ask is, are you clear what your authority is here, your scope of jurisdiction, you know, in a legal sort of way? Because what happens is, and this has crippled ethics committees over the years. When I was at the Hastings Center, I was consulting with a hospital up in the Westchester area, and this pediatrician, who was the head of the ethics committee, thought that he really was in control of everything, and he thought that the ethics committee was blessing and doing all kinds of things. He was well out of his scope of jurisdiction. Who has the authority? The patient or the patient's family, but not this bozo pediatrician who was kind of assuming. So we always ask people to say, okay, do you know what your authority is? Usually these committees aren't decision makers, they're there to facilitate. So then we go to the second question that we look at is, well, it's very important. I take ethics. My quick way of saying what ethics is about, it's all things considered, right? You got to walk around the problem a lot of times to see all the issues. And one of the things that happens is, oftentimes people who could be affected by a decision are overlooked. So we've already named some people who would be affected by this decision. The woman, her family, the nurses, the institution, and things like that. But what's also important to think about in this question is, how are they affected? One of my areas of study is called organizational ethics, about how executives live in their natural habitats, how they think. And one of the things about executives is that they have blinders, and they oftentimes don't see all the people who could be affected. So we've built into the values-based decision-making, we ask people to say, well, how are they affected? So let's think about the nurses. How are the nurses affected by this case, would you imagine? Whether if they were to terminate treatment or not. Let's imagine how they would be affected. Yeah.
It could go against their conscience.
Yeah. Yeah, right, and you know what? It's like holding your nose and like, right. So it could go against their conscience, and they could feel coerced to doing it. And by the way, there's a big literature out there. It's on nursing moral distress. When nurses are asked to do something that they don't want to do, they call in sick, or they seek transfers to other places. It's a very severe issue. When people are being asked to do something against their conscience, it just rips an organization apart, right? So that's how the nurses are affected. How do you think the church is affected in this one? Because they are one of the interests here. Well, how do you think the church is affected here? Any thoughts? Well, they're affected without knowing the full facts of the case. If they thought that Holy Smoke Hospital was treating people to early deaths, it certainly would cut against. They might say, well, you can no longer call yourself Holy Smoke. You can just be called Smoke Hospital, right? We're taking the Catholic title off of your billboard. Well, it's very important, and here's a list. It's in your notes. The woman, of course, her husband and kids. I mean, her husband is imagine having your wife tethered to something where you know what she said and you believe she shouldn't be on that, and someone sort of forcing treatment on her. So you could imagine if it were to continue, but you could also imagine if when she does die, or if he does, that he has his kids to think about. What we do in values-based decision making is try to get people to imagine both the pros and the cons, the risks and the benefits of everyone who is affected. Okay, that's the second one. The third thing that we do is, well, what data do we need? What do you think we need to know about this case? Usually when you sit down for the first time, you don't have all the facts at hand. What would you say are the issues that you need to think about? Yeah?
The extent of the disease process.
Yeah, right. What's going to happen to her? Is she going to come out of it? Things like that. What else do you think you need to know? What else would you need to know if you got to go out and gather more information to think your way through this? Yeah?
Well, what are her vitals? Like, how well is her body operating right now as opposed to before?
Okay, right. Yep.
Maybe review other similar cases.
Yeah, right. Well, what have we done in the past when we have these sorts of issues? What does history tell us? What else do you think is necessary information to make this decision? Yeah?
Not just what the law says, but what the church teaches
Yeah,
about it.
right. So what can you do in the state of Pennsylvania? And here's one thing, that anyone in this room, by state law, and this is nationally guaranteed, you can forego life-sustaining treatment even if you're not dying. So there's the law. It was permissible, right? Okay. Look, you say, and what does the church teach? Well, tell me. Take a wild guess. And what do you think?
The church teaches that you must give life sustaining.
It does? Okay. Well, we're going to play with that, because that's a very... Does anyone think to the contrary of that? Yeah.
Well, the church says that you need to feed someone. They can't die by starvation.
Uh-huh.
Like you could forgo other life-sustaining treatments, but starvation is not one that you
So A&H, artificial nutrition, hydration, can't starve. That's what we think the church is saying. We're going to get to that in a bit. Yeah.
I think it's this idea of ordinary versus extraordinary means.
Ordinary, extraordinary. Ordinary, okay. Extraordinary. We'd have to have some storyline about that. What does that mean? So the church teaches about ordinary and extraordinary. We're going to look at that in a second. Anything else? Yeah.
Well, even though she does have like a next of kin and her husband advocating for her, you might want to look to see if she had some legal advance directives.
She does. So, but we want to see what are her advance directives. She did appoint her husband. He was right, and that's always important in all instances. Has the person told us what they want, either in a legal document or have they spoken to someone? Good. Well, so will she recover? Is she terminal? People thought that they would want to know that. We'll see why that might be relevant. What were her wishes? What is the law? What is the church teaching? Well, let's just go. I told you what the law, in fact, is here. And even though it was pretty premature by the neurologist will not make a determination that the person is in a vegetative state. It takes 3 months for them to do it. If they know how the person got that way, and we know how she got that way through anoxia, if it had occurred, for example, through some sort of organic brain syndrome and the like, it takes a year to determine that kind of stuff. So, but even so, it was too early to say, for example, that she was terminal on that one question. Why? For all the people who wind up in a vegetative state, a third of them remain in a vegetative state, a third of them come out of it, and a third of them die. within a 6-month period of time. So to say she was terminal, at least it was precipitous. It would be rushing the gun to do this, right? So one of the most important questions that we had to ask, well, what does the church teach? There was this Pope, now dead, Pius. He shows up to a bunch of cardiologists and he's talking to them. This is 1958. They just figured out how to do CPR. And he says, he's opining about, a theory that had long been in the church. And he was trying to distinguish between appropriate termination of treatment, what in the past had been called it's extraordinary treatment. If it's extraordinary, then it's appropriate termination. If it's ordinary treatment and you forego it, then it's inappropriate. You've done something equivalent to kill the person. So he says to the group of cardiologists, he says, normally one's held to use the ordinary means according to the circumstances, places, and the culture, which is basically saying, he's admitting that if you don't know how to do CPR, or you're in sub-Saharan Africa and you haven't taught the people, if you don't do it, you're not morally negligent, right? So he says, that is to say, the means that do not involve a grave burden for self and others. So here, this is the general tradition. If you can show that the treatment creates a burden, and by the way, and it doesn't get you a lot of benefit, then if you forego it, grave burden, not a lot of benefit, then it's appropriate, or what people would call extraordinary, right? We also looked at the Congregation for the Doctrine of the Faith. This is the chief teaching arm over in Rome. And in 1980, they had a clarification. It's called a declaration. And we used to use the words ordinary and extraordinary, but that confused everyone. So you talk to a nurse and you say to the nurse, well, is it ordinary and extraordinary? And the nurse would scratch his or her head and say, well, we do it a lot. It's easy to do. Doesn't cost very much. That's what we do around here. We feed people, things like that. And that was a description of the action. It wasn't a description of the morality of the action, right? So they clarify it and they say people prefer to speak of proportionate and disproportionate. If the treatment we're giving you creates a disproportion of a burden, and by the way, you're going to die soon anyway, not a lot of benefit. We could do it to you. We could thump the hell out of you, but we might get you kind of started again, but you're not going to live till discharge, right? Basically, they're saying that if you can show a disproportionate burden with not a lot of benefit, it is an appropriate termination of treatment. It's because there's disproportionate, great burdens, and not a lot of benefit. However, if it's proportionate, that is to say, someone, for example, could live a long time, and by the way, it's not all that terrible to give, then you may have to take it. So the facts that the ethics committee needed was, well, what does the church teach on this? Well, what would you say at this point? Would you say the treatment to feed her and to give her treatment was a burden? What were the burdens, and what was the benefit? Let's start there first. What was the burden, and what were the benefits? Anyone want to take it? Yeah, go ahead.
Well, I think it would be a financial burden.
It's a financial burden. That's right. I mean, ICUs are not inexpensive kinds of places to hang around, right? Okay. More expensive than the Hilton. Okay. What else? So that's a burden. What else? Yeah.
They weren't against what she wanted.
It's a burden. If someone says, I don't want this, and then you go ahead and do it to the person, you're at least dishonoring their wishes. A kind of a do unto others as you want them to do unto you. It's sort of disrespectful if you're going against their wishes. That's a burden. What else? What else? Is it Java time? Go ahead.
It would be an emotional burden on the family because
Right.
the father had already told one of the daughters that their mother was dead.
That's right.
That was an extreme
Right.
emotional
Right? A burden on the family. What are the bennies? What are the benefits here? No benefits? No benefits? What? Life. She's gonna get. Yeah, go ahead.
You respect her autonomy, her wishes to be pulled off.
Okay. So a benefit to foregoing it would be, following her wishes. Well, we went to the tradition, and so we went to what Pius said, what the Congregation for the Doctrine of the Faith said, And we, in Catholic hospitals, follow, I should have brought it with me, a set of directives called the Ethical and Religious Directives. And directive number 32 is probably the clearest. It says, while every person is obligated to use ordinary means to preserve his or her life, no person is obligated to submit to health care procedures that the person has judged. Not the people outside protesting, not the nurses, not the doctors. What the person has said they thought was a burden, right? They should be obligated to submit to health care that the person has judged with a free and informed conscience. She had told her husband before she went in for this mitral valve thing, she told him exactly, not to provide a reasonable hope of benefit without imposing excessive risks and burdens on the patient, or, notice what they say, it's not just the burdens but expense to the family and the community. Now, so here's what the church. So we were thinking this through. The church says, what counts as excessively burdensome? Well, if it's too painful, or people who are going to have their legs removed because they're gangrene, and say that I don't know if I could live my life without my legs. It would be terrible. But the psychological trauma of it, that's a burden. Too psychologically repugnant, too damaging to the self, to prohibitive cost, and burdens apply to not only the patient, but to the family and to the community. Now, this is where this story gets really complicated, because another directive says, well, euthanasia, that is to say, let's read what the directive says. Euthanasia is an action or an omission, something that you do, or something that you neglect to do, or you take it away, you withdraw, is that by intention causes death in order to alleviate suffering. By the way, I deal with executives and doctors, right? And they read this, and they say, what the hell are they saying? And that's what you might just be saying. Like, what's going on here? This is called Romanutia. It's written in very, by canon lawyers and others, and they use very specific language. Well, they're saying, basically, euthanasia is one of those inappropriate. By definition, within the church and general society, if you're caught doing an act of euthanasia, treating someone, killing them, it's on the inappropriate. Now, the problem here, of course, is, well, how would you know when that happened? I mean, I'll give you a case example. We had a 37-year-old postal worker who had moderate MS. And she didn't want to take antibiotics, and she wanted pain relief. She kept getting urinary tract infections. And her request was based on this: I don't want to live like that. When someone says, I don't want to live like that, what is it they're possibly saying? What does that mean, I don't want to live like that? Is it one of these acts? Is it an act of euthanasia? What do you think? Well, whatever it is, it's not clear to the outside. I mean, when someone has an intention, it's inside. And we don't have little stethoscopes to go in and see what people are intending. The only way we know what people are intending is the language that they use. And one of the interesting parts of language, it's deeply confusing. I don't want to live like that. Well, is it on this side, inappropriate, or is it on this side? When the guy says, my wife doesn't want to live like that, she told me what she wants. What is he intending? It's not a meeting. Does he want to get her dead? Or does he want to follow what she wants, right? So, it's one of the real challenges in doing a values-based discernment is, intentions are such a thing that they're not obvious to the person, right? So, I guess, do you treat the principle double effect in your course? One of the facts that we had to get out was, okay, we have a moral rule called the principle of double effect. It says that every time you make a choice, it may have several different effects, and you're only responsible for your direct intention. It's like the butterfly effect or the chaos effect. The butterfly flaps its wings, and we have a tsunami happens, in the South Pacific, right? You're only responsible for your primary intent. So, how does this work in end-of-life care? Someone's handing someone a lot of big burdens. Here's a big bucket of burdens. And by the way, even if you are to get it, you're not going to live very much longer, right? So, and the person says, hell no, I don't want that. Even though they reasonably foresee and accept the hastening of your death. In this theory of the principle of double effect, what is the choice there? The choice is, so when someone's handing you big burdens that's not going to get you very much, it's kind of, oh, I don't want that. I don't want that. That's your problem. Even though you reasonably foresee and accept that you will die. So that, the ethics committee, as we were doing this values-based discernment, was trying to sort that out. And when I asked you, well, where are the burdens? All that I heard were burdens. I didn't hear even very many benefits. So if I just took the aggregate of what you all were saying, there's quite a lot of burdens and not a lot of benefit. So we're okay. We have time. Okay. So then the next step in the values-based discernment is, so what ought to be driving this? What are the values? What values do you think ought to be driving? I heard some values when we, one value is one of personhood, right? We could say that that's a value that we're trying to protect or promote or advance, or at least not do immediate harm to it. What other values, what values ought to drive this? This is one of the more difficult parts in moral reasoning, because we all describe values differently. Yeah?
Charity.
Charity, and how does that play as charity? Okay, how does that play?
It's sort of like caritas, a non-self-involved love. Like,
Okay.
Willing the good for another for
Okay.
their sake.
So willing the good. Okay, and obviously when we bring up values, they're doing some moral work. They're going to push us towards a conclusion. If you were the person and that was the key value was driving, where would that lead you?
Well, I think that willing the good for another person sort of implies a gratuitous act.
Mm-hmm.
You don't. It just. I think it's really important in cases like this because it doesn't take into account like things like financial strain coming into play or whatever.
Okay.
It's sort of. It's just
Pure generosity
Yeah,
towards the individual? Okay, so could I infer from what you're saying that if he had caritas for his wife, he'd keep her going for a long time on that? I'm not sure what I
not
can infer.
necessarily, but he wouldn't
Okay.
take into account like financial burden.
Okay,
Like that wouldn't even matter to him.
Okay.
He would have other concerns.
okay. What other values ought to play here, do you think? That you think ought to be, considered or would drive the decision? Things that are valuable. Other values? Someone's turning up the heat so much that we're all going to pass out in a few minutes. Yeah, go ahead.
Justice would play a big role.
Pardon?
Justice would play a big role.
And how justice in what way? Justice.
Well, justice for the patient in the sense that you need to do what is right for her and
Uh-huh.
what she would want.
Okay.
But also justice for the hospital, that they need to do what they see
Okay.
fit and kind of have to meet in the middle.
Good. I mean, so you can see when values are brought up. Any other things that yeah, go ahead.
Sanctity of life.
Sanctity of life, right. Sanctity of life. And I suppose that would cut in this way that we've got to keep her going?
I think it could go the other way too.
Okay.
Maybe like a quality of life issue.
Uh-huh. Okay. Another value, a quality of life. It's quality of life. You want to say something about that? You want to say anything about that? Okay, you're yeah.
I don't think quality of life can come into play. I mean,
Uh-huh.
like, everything I've read,
Uh-huh.
things like Leon Cass,
Uh-huh.
like, there's just an inherent problem when you bring in quality of
Uh-huh.
life to determine whether or
Right.
not someone's life should be kept going.
Right.
It's too impossible to
Uh-huh.
just determine what is a good life, because is someone, with 40% of brain function,
Uh-huh.
are they living a good life?
Right.
Do we think so? And,
Right.
and are we biased in our judgment?
That's
are
right.
we being biased
Right.
against a disability?
Yeah. Right.
Is there a problem, like with the baby dough regulations?
Yeah.
That was all about quality of life.
Right.
Like, do people with Down syndrome have a good quality of life? Like, maybe not. Maybe
Uh-huh.
we should just discriminate them. And it's just, I think that's too hard.
Future philosopher of America, right?
I just want
Father.
to clarify that.
Yeah.
You can't make, it's very difficult to make quality of life judgments about another.
That's right.
But we always make quality of life
That's
judgments
right.
about ourselves.
Yeah.
The woman made quality of life judgment about
Right,
whether she wanted
right,
to go to
right. But you know, the position you're articulating that Leon Cass had, John Paul II, the former pope, had in his allocution said roughly what you were saying. But you know, and I think what Father is saying is it should be observed. When I go onto the floor and I'm listening to the nurses and I'm listening to the doctors, the thing that they bring up all the time is the quality of life, the quality of life. Now, if the person has made that judgment about themselves, that's more clear. But there's a whole group of people, they're called not dead yet. There are a lot of persons in wheelchairs and the like, or persons who have disabilities, and they're really loath to have those kinds of judgments made. So we try to identify what the key moral commitments are: sacredness of life, respect for the person, autonomy, and really the use of resources. Some of the things that were mentioned here. And, you know, one of the problems in all moral reasoning is which of these should be given priority. That's one of the big, if you take further ethics courses, trying to figure out which should be given priority and therefore which will drive the ultimate choice is one of the biggest moral theoretical issues that's out there. Then we establish priorities among the commitments, and we get our people, whether it's an end of life or it's an organizational ethics, you know, we always say, well, what are the options? Well, one option is keep her tethered, keep her going. A second option would be, well, you know, something in the middle. Well, we'll keep feeding her, but we'll stop everything else. Or we could start it, you know, stop it immediately, right? So it's always important to sort of, in moral reasoning, I always get people to think along a continuum. What are the options of them? And then what are the burdens and benefits associated with each of those options? So we develop the options that support whatever value we thought should be given prioritized. So here are the options. Follow the husband's request, right? Take her off the vent. Another option that people were saying was, look, we don't think he said that thing about his wife was already dead. Appoint someone who will go out and a guardian ad litem. What they do is they find out, what did that lady want? And they bring it back to the court and they give it to the judge and they say, this is what the lady wanted. So if another option was, okay, now notice, remember when I first said we had these two questions, who decides and when to terminate treatment? Well, they didn't like his decision. So let's go around it. That one happens so frequently on the floor. Get that family out of here. Let's go to the court. Well, I mean, you know, kind of disrespectful of the guy whose wife it was, his wife. Yeah.
Well, I think you have to have a little bit of sensibility too, because I mean, usually in most cases, a decision like that, it's not easy.
Mm-hmm.
So, you know, I don't think the husband wants to make that decision. So
Right.
You have to be sensible to that part too.
Absolutely.
And, you know, maybe talk to the family first.
Yeah, you're raising, you know, in values-based discernment, these things happen oftentimes when these are the last resort. But you're expressing a very important pastoral concern. Most people in bioethics, you know, the professional ethicists among us, would say, well, look, you know, before we get to a standoff, do we really know what the people want? Do we know what their wishes are? Have we spoken to them? What is he really up to? So that's an important way, and you know, trying to figure out what his interests are. Has the person been heard? They're in the bioethics movement where they do consultation. It's called ethics mediation or consultation. That's the most important first move that we have to make. You know, did anyone really find out what they're really up to? What his real desires are? Was he trying to protect his kids? Was he trying to, just follow his wishes and honor her and things like that? So we applied I told you what the double effect was, but now, so the question is, what do you think, if he were to decide, do you think that there's a great enough burden with not a lot of benefit? What do you think? Or do you think that, so would it be disproportionate? There's too much burden and not a lot of benefit? Or is it proportionate, that there's burdens, but there's lots of benefit? Yeah. Oh, you're just, okay. What do you think? Well, you know what, I always think of a continuum and end-of-life cases. Here's the easy one, easy cases, and the difficult cases, right? And the easy cases are those where, let's take a 92-year-old woman who has bone cancer involvement, and she's going to die from that soon. And the question is to her, do you want CPR if you were to arrest? And she says, no, I don't want that. You know, you can think of two ways of dying. You can die, or you can die having the bejesus thumped out of you, right? So you could imagine why someone would say, well, look, there's a lot of burden, and even if you thump on me, I'm probably not going to live till discharge, right? That's the easy case. It's kind of testing our moral intuitions inside. The more difficult case is someone who we could do a lot to, but they'll die. Let's take a 50-year-old man who gets cancer, and he's going to have to take experimental treatment. It's going to cost a lot, and he's going to die a year from now. These in moral theology are called the old chestnuts, right? Well, you know, the guy says, look, I've been saving my 50 years to put my 4 kids through college. That's real important to me. So I could, if I take the treatment, I'll expend all the money that I was going to use for them. And by the way, as I'm taking the treatment, I'm going to be vomiting my head off. So, and that's not a pretty picture. And by the way, at the end of the time, I'm going to die. So if someone says to the guy, do you want to take it? And he says, no, there's too many burdens. I'm not going to be able to pay for my kids. I'm going to be vomiting, and I'm not going to get very much because of it. Generally, the thought has been, he probably can forego it. It's probably disproportionate, and he's not getting a lot of benefit out of it, right? So people have generally thought, while it's, you know, there's a lot more life. The guy could have a year. He says no. The most difficult cases are those for whom we could keep them alive for a long time. They're the vegetative state, a permanent vegetative state, PVS, right? Because those individuals, we only have 2 of them. In all the beds we have across all our system, we have 2 of them. One of them has been at this nursing home for 39 years in a vegetative state. He was a bread truck deliver great union benefits. His truck was hit while he was on work, and that benefit has kept him in that nursing home with the best care for 39 years, right? Well, you know, so he has a lot of benefit getting that. But, you know, so what are the burdens there? These are the most difficult ones and I always get people to kind of think, start out with the easy cases where there's a lot great burden and not a lot of benefit. So we, again, as we thought about our options, we went to another one of the directives that says, a person may forgo extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgments, and we know what her judgment is, we pretty much know she's never going to get back to 50% functioning. She's probably not going to have very much functioning at all. By the way, I'll tell you in a bit what the end of the storyline is. Doesn't offer a reasonable hope of benefit or entail excessive burden. So at least on this directive, and by the way, these directives are little pericopes. They're just like little short stories that stand on the shoulders of a very large moral tradition. So they're just like little bits, snippets of DNA. So when we're looking at this, we kind of step back and take a broader view of it. Now, here's where it really, and this is where the storyline about could we remove nutrition hydration. Recently, the Catholic bishops looked at these directives, those 72 that I was talking about, and they looked to one directive in particular, and it was about nutrition and hydration, and they changed it. Well, they didn't actually change it. They simply clarified it. And this is what they said. As a general rule, you know what that means? Here it is again, Romanutia. They're using very specific language. As a general rule doesn't mean in every case. It means as a general rule. As a general rule, we feed people. That's what this is saying. There's an obligation to provide a patient with food and water, including. So even if you're giving it through a peg tube or a hyperalimentation, as a general matter, we do that. Okay. This obligation extends to people in a chronic condition, and they actually add, and this is the clarification, people in a vegetative state are really in a chronic condition, right? So to the point that was made back there a little earlier, who can reasonably expect to live indefinitely if given such care. Medically assisted nutrition hydration becomes morally optional when they can't reasonably expect it to prolong life, or when it would be excessively burdensome for the patient. Well, the patient has told us what she wanted, at least. It's not irrelevant what she wants there. If it causes significant physical discomfort, for example, resulting from the complications used in the use of the means involved. Let me give you an easy case over on this side about nutrition hydration. My dad drank and smoked all his life. He got esophageal varices. It's kind of inside your throat, right? And what happens is they grow, they get constricted, and then they explode. So, and when you take them, when you try to eat, you cough, it's a horrible, horrible thing. So we couldn't feed him any longer, and he agreed to have a tube put in because he wanted to live a little longer. We put it in, and he started vomiting. I mean, imagine where you can hardly breathe, and you have all this liquids in your thing. Well, but my dad wasn't going to live very much longer anyway, so he finally said, I don't want any more of that. The bishops, in laying this out, clearly see that there are times where the provision of nutrition and hydration clearly fit on this side, where there's great burdens. I mean, imagine choking to death, right? And by the way, you're going to die anyway, even if we do feed you, right? So they're basically allowing for it, but they're suggesting that on these kinds of cases where the person's chronic, we're going to have to, continue. For example, as a patient draws closer to inevitable death, the underlying progressive and fatal conditions, certain measures to provide nutrition and hydration become excessively burdensome and therefore are not obligatory. Who's the category of people? We have tons of people in our nursing homes who have terminal Alzheimer's. They don't know how to eat. They're pushing people away. They're totally disoriented. And they're dying with that Alzheimer's. So what they have in mind, the bishops, is at least these are acceptable. But there are other ones where if the person could live a long time, well, red flags ought to go off if you're taking nutrition hydration away from someone. Simply, the only reason is because they're in a vegetative state. Oh, vegetative state? No, they're not going to get fed. If that's the only reason, that's a bad reason. So, these are the benefits and burdens of nutrition hydration. Then we sit down and we have we do a little bit of a discernment. And in this instance, it was pretty clear that she was, the neurologists were clear, even though it would take 3 months, that she was going to die of this. She was never going to gain any sort of ability because she had been anoxic so long. So what she had said was clear. And moreover, she wasn't going to be coming out of it. And so a judgment was made that we could forego life-sustaining treatment. Well, interestingly enough, before they ever got to untethering her, she died. She died. So in some ways, the very act of removing the hyperalimentation, we never had to get to it. But I mean, she was so close. So we came to a judgment. But of course, part of the problem of values-based discernment was, well, we got all the way through it. We came to a decision making. But the most important thing was we still had a lot of nurses up on the floor who really thought that this was equivalent to, killing. And so one of the follow-through in all values-based discernment is, well, you got to go up and you have to create educational sessions for people, because if people go home and they think that they've been party to a murder, they're not going to show up for work. They're going to leave. They're going to flee your hospital. So part of our follow-up was dealing with the moral distress of the individuals. Now, so the first question I asked was, well, how big a deal was this? Well, it probably could have been dealt with by the ethics committee alone, maybe adding a few individuals to it. But there are some cases. For example, the case that I was telling you about, the 37-year-old person with MS who was quite, moderately disabled. We didn't use the ethics committee for that. We brought together some people, including in the diocese where this was happening, because the bishop, a nurse, had called a bishop, and the bishop had his lawyer call me and said, "We think you're killing. If you go along with this lady who keeps getting the urinary tract infections, you're doing something that you can't do." So in an instance like that, where there were many other individuals, including the bishop now, who's kind of looking at us down we decided that we should not just use our ethics consultation to deal with that. So I did that, and I still have 5 minutes to spare, and so I'll open it up. There you go. Yeah.
How long did the decision process take?
Well, you know, on this case, we met twice over it. In this instance, for this very case, twice for 2 hours. However, as I said, when we decided about just wage, which was a very big, what does a just wage look like in Catholic Health East? I managed people's expectations, and I said, we are going to meet probably for 6 months, and we're going to need a heck of a lot of time because it is a very complicated. So it depends on how big a decision it is. Well, when I had to transition some nursing homes, we were selling them, basically. That's code, transitioning. It took me 3 Saturdays, full 8-hour days, to get the boards of that organization to say, you know what, this nursing home it's unsustainable. We can't do it. So it really does vary. You know the case of this woman with the MS? That went over 6 months. She would refuse antibiotics. She would get the urinary tract infection. She'd get so sick, we'd take her to the hospital. She would come back. She was flipping back and forth between the hospitals. This lady was, as they say in New York, this lady was shuggy, mashugana, nuts, right? She created such hassle, both at the hospital and at the nursing home. So some of these can go on for quite a long time. I try to manage expectations. What else? Yeah?
Did any nurses end up leaving in this case?
No. You know, we did rounds on the floor, and then we had grand rounds for the hospital, and I could say that, you know, some people still thought, you know, you want to give people the information. What does the church teach, and how do we think about these things? But sometimes people, you know, I'm not going to force them to come to the same conclusion, and I know that there was at least one nurse and one lawyer who was involved, who thought that you couldn't do it. Other comments or observations? All righty then. I think we're done.
Thank you.
Okay.